in part 2, we have phases of a clinical trial and introduction to metabolic research. Our first speaker is going to be Ms. Barbara Harmon. Ms. Barbara Harmon is an adult nurse manager with over 31 years of experience at New York Presbyterian Hospital. Her time at NYP was established as a staff nurse before becoming a patient care director, then a clinical documentation nurse, and now clinical manager. In addition, she is the co-founder of My Empowerment Place, which helps empower parents and children who have stress through holistic medicine methods and harnesses the power of healing through Reiki sessions, sound healing, stress reduction workshops, sleep, aromatherapy, meditation, and mindfulness. And I said all of that to introduce you to Ms. Barbara Hormann, who's going to talk about the nurse's role in clinical trials. Here is Ms. Harmon.
Hi, everyone. Thank you so much, Lula May, for that lovely introduction. I welcome you all to our second community class. And let me share my screen so we can start. Okay. Can everyone see my screen?
Yes, I see it.
Okay, perfect. All right, so today I'm going to be talking about the phases of clinical trials and the introduction to the nurse's role in those clinical trials. So the first phase, as would be logical, is called phase 1. And that's all about is if that drug or treatment is safe. They're also called first-in-human studies. They're typically done in a small number of volunteers, so normal people that don't have any disease, or it could be done in a population that has a disease like cancer or ALS or whatever the targeted drug therapy is for. They may use that specific population, and it's done in a very controlled setting. Because these drugs have never been given to humans before, they've been given to animals in preclinical studies. The patient or the participant is watched very, very closely, and safety is the main concern in that trial. And we're looking to see how the body reacts to that drug or that treatment, and how that treatment or drug reacts to the body. So if we had one study where we gave a drug that was, believe it or not, the base was from a jet fuel. And they found in that phase 1 study that direct injecting it right into the vein really, really burned. So we had to, the study team stopped the study. They worked on getting a way that it didn't burn so much. So these are things that they're looking for in these phase 1s. And it's unlikely to have any effect on the person's disease process. So there'll be no therapeutic effect. And that's one thing that clients need to know very upfront if they're in a phase 1 study, that chances are that nothing will happen, because this is really the safety phase of it. And the doses of the drugs, if it's a drug study, usually start very low, and then they increase gradually based on the side effects that the participants have had. And this phase can last a few weeks to a few months, and then they analyze the data and decide whether it can move on to that second phase, which is phase 2. And that question that they're answering at this phase is if the drug or treatment works. So in phase 1, they've established that it's safe. Now in phase 2, we're going to see if it works. So we're going to continue that testing as a randomized controlled trial. And that just means that somebody could be given a placebo, which means that there's no active drug. Or if it's a treatment, that there's no real treatment in that, whatever they're doing. And this is done in larger numbers of people. And it can be normal volunteers or the people that have that disease. I already talked about the placebo. And the reason that they do these placebos is to see if this drug or treatment is really working, or if there's that placebo effect. So sometimes if you take a pill that's just sugar and you believe that it's the real drug, you may have the stated effects that we're expecting. So that's called the placebo effect. So that's why in this phase 2, we're testing to see if it's really the drug that's working or the placebo, or if there is that placebo effect. And sometimes we're blinded at this stage. So we may not know if the participant is getting the drug or the placebo. Most of the time that's the case. We don't know if they're getting the drug or the placebo. And at this stage, there may or may not be any therapeutic effect. So it could work, but there's a chance that it may not work. And the dose, it just depends on how the study is designed. All the participants may get the same dose in this phase, or there may be an escalating dose again, depending on, like I said, how the study is designed. And this phase can last from a few months to a few years. So this one's longer than that phase 1. And I found a statistic that said only about 18% of the studies go on to the next phase. So a large number, unless there's real problems, go from phase 1 to phase 2, but less than 20% of studies go from phase 2 to phase 3. And next we'll talk about phase 3. This phase is all about seeing whether a drug or a treatment is better than that gold standard treatment that's given as a standard to anybody that has that disease. And that's done as a multi-center randomized controlled trial. So phase 2 may only be done at 1 or 2 or 3 institutions. These phase 3 studies are done across the country or across the globe. So a study can be going on here in New York, it can be going on in Zurich, Switzerland, it can be going on in Africa, anywhere in the world, these studies can be taking place. And at this phase 3, it may be done in a hospital or it may be done in a doctor's office. So if you go to your doctor's office, they may be able to do a phase 3 study in that doctor's office, depending on what that study involves. And a placebo may be used at this point as well, but it won't be given alone. So in phase 2, the placebo may be given alone, but in this phase 3, because it's further along, they will typically not give that placebo alone. They'll give it with another drug or treatment, or if they do give it alone, they'll do something called a crossover, where the participant gets the drug or treatment at another portion of the study. And the main goal of this phase is to test the effectiveness of the drug or the treatment. It's also called the pre-marketing phase because this is the last step before it goes to the FDA for approval. And these studies, because they're so big and involve so many people, they can be very expensive to run because they've got to provide, more than likely they're providing the drug or the treatment free of charge to the subject or the patient, the participant. And as I said, this is the last phase before FDA approves them, so they're doing the application during the phase. And about half the drugs are successful and go on to approval. So I'm not defending the drug companies in any way here, but this goes in part to show why sometimes drugs are so expensive, because these trials take so much money to run and work out. So at this point, after phase 3, if it's approved, it can be marketed to whatever group or disease patients that the study was run for. And then there is, you would think it might end here, but it doesn't. There's also a phase 4. And that phase 4 is done if we need to know more information about that drug or treatment. And it's also called post-marketing surveillance. And this is done after the FDA approves it. It can look at things like quality of life, if it's cost effective to have this treatment out there in the world, any long-term side effects and any long-term benefits that there may be. They may also, in these post-marketing studies, compare 2 FDA-approved drugs or treatments. So that's called a head-to-head trial. It can also be done to prove that it works for one disease, and they're trying to prove that it works for another disease. So a classic example of this is Viagra. Most people don't realize that Viagra is a heart failure medication. They also found it worked for the male, I'm just blanking on the phrase that I'm looking for, but it also worked for males as well. So they did a study and it proved that it worked in both arenas. So now they can market Viagra for both of those purposes.
Ms. Hormann, you have 5 minutes left.
Okay, thank you. And these are performed in very large populations and over a long period of time. So a post-marketing study can go on for 5 years, 7 years, 10 years. So these can be quite long studies. And if harmful side effects are shown during this time, then the drug will be pulled from the market. And some of the weight loss drugs back in the 80s and 90s, like fen-phen, because of these post-marketing studies, the drugs have been pulled. And finally, we'll talk about the nurse's role in clinical research. And as any nurse, I believe the nurse's role in these clinical research is to be the participant's or the patient's advocate. And that involves making sure that the participant understands what the study involves. Because if you've got cancer and you hear that there's a clinical trial, you may just say, yes, I want the drug, no matter what. And you may not understand that there's a chance that you may not get that medication or that it may not work. So the nurse's role is really to make sure that patient or that subject or participant, whatever word you want to use for somebody that takes part in a research study, involve what that study involves. We also administer that treatment or that drug. We perform the study activities like drawing the blood, doing EKGs, all kinds of data collection. We observe for the participant's response to that drug therapy. We observe for side effects, and we're kind of the gatekeeper to make sure that nothing gets done to that participant that isn't part of that consent form. So anything that's done in a study has to be laid out in that consent form. So there's no question, no surprises. And that's a big part of the nurse's role, to make sure that nothing is done and to protect that subject. And some nurses may be investigators or co-investigators and perform roles like obtaining consent, determining eligibility, and just doing anything really that the study needs. So that is the end of my presentation. I left a couple minutes for any questions. If anybody has any questions.
Would you care to comment on what's going on right now where the FDA is playing with a 2-month window on the phase 3? Is there an industry standard for a minimum time? Can you give us some context on that decision? Never mind the politics, just professionally.
I believe this for the vaccine trial to be at the phase 3 at this point, it's been fast tracked.
Yeah.
So phase 3s usually take a couple years to get to a phase 3. It's probably been about 1 to 2 years. So to get from a phase 3 to approval is usually much, much longer. So it's not surprising that they are looking to wait and see and get more participants involved to see about side effects.
Oh, I don't doubt that. It's the other way around. What's the minimum time on average if there are side effects? Sometimes they don't show up immediately.
Right.
Is it average 6 months at a minimum? Average a year is a minimum? What's typical? Never mind the emergency nature of what we're doing right now.
I'm not 100% sure of that, but I do believe that it's at least a year.
So 2 months is unwise?
I'm not qualified to comment on that.
Don't want to push you in the wrong directions. Okay, got it. Thank you.
You're welcome.
Okay, does anyone else have a question? If not, thank you so very much, Barbara, for the informative information you've given us about the nurse's role in clinical trials, because we can't do clinical trials without nursing and
That's
nursing.
right.
So thank you so very, very much.
You're
Now,
welcome.
we're going to have Dr. Katie Hoopman. She's the director of the Nutrition and Metabolic Research Core here at the CTSC. She is a certified dietitian and a nutritionist. And Dr. Hootman has used her knowledge and expertise to contribute to the scientific community with 16 publications. For that, an applause. But thank you so very much. Dr. Hootman just loves giving these talks. So you guys, your guys are in for a great treat. So
Great.
Dr. Hootman.
Thank you so much for the kind introduction. I will share my screen and we'll confirm that it's displaying correctly and then we'll move forward. All right, oh, there we go. Can you see the screen, Nutrition and Metabolic Research?
Yes.
Yes.
Wonderful. All right. Well, it's a pleasure to connect with you. Let me move the Zoom boxes. Great. And discuss the CTSC Nutrition and Metabolic Research Core, our team and our activities. We'll discuss some of the video content that you reviewed before class regarding the social determinants of health and health disparities, two really important topics. Agnes will let me know if there are any questions in the chat, and she'll make sure we're running on time towards the end. If you have questions along the way, send the chat and interject. All right, let's begin. So a few objectives for today is we'll review, as I said, the concepts from the digital content you watched for class today. The social determinants of health and minority health disparities are complex and rich disciplines. They're really entire disciplines. In our short time together today, we'll just scratch the surface with basic concepts and discuss some evident examples. From there, we'll move on with a deeper dive into information about nutrition research and the variety of activities of the CTSC Nutrition and Metabolic Research Core. We'll wrap up with a few questions for discussion and any questions or topics you would like to discuss. In the animated video by Let's Learn Public Health, the social determinants of health were defined as the conditions in which people are born, grow, live, and age. These factors have a large influence on our health. It also determines health inequities, which is the unfair and avoidable health differences between different groups of people. This video also explores social determinants of health and offers a useful framework in which to understand them. I really liked this video, not because animations are fun to watch, because they are, but I think the voiceover and the animators did a great job at explaining some really complex interrelated factors. Let's take a look. So this is an image, a graphic from the video directly, and the animators depicted the World Health Organization's framework for conceptualizing social determinants of health. And as we can see social determinants at the top, it breaks down into two basic categories, being the structural determinants and intermediary determinants. And from there, there's a whole host of different factors, we could say, or different characteristics that fit under each type of social determinant of health. And as you can see, there are arrows going back and forth. There are bi-directional relationships, and some of these variables are actually really complex. They're actually, they have a lot of information in one word, for example, like occupation. There are a lot of different implied pieces of information that you can learn about someone based on what they do for a living. You know, what is their day-to-day like? Are they sitting most of the time, or are they active? Are they doing manual labor at their job? That can give you some insight into, you know, what their day-to-day is like. Also, the socioeconomic position variables, those really tend to come out when we talk about social determinants of health, although they're not necessarily the most important. We see that structural and intermediary determinants are interrelated and both contribute to health. So under the intermediary determinants, we have some material circumstances as well as psychological factors, behaviors, and biological factors. And this overlapping group here, social cohesion and social capital, those can overlap with both types of variables or types of determinants. Where do you think diet would fit? So if you were looking at this scheme and thinking about these different types of determinants of health, and you see the cartoon of the different boxes, if you were to think about, you know, what someone eats and drinks on a day-to-day basis, where do you think that usual diet would fit in this diagram? Anybody wants to chime in? I don't know if we're doing live answering.
Behavior is biological.
Great. Anybody else trying to chime in? Kind of looked like it.
I think diet is a combination of behavioral and other factors.
That's it. It's definitely in this intermediary box, and it's here in this diagram, it would fit the best under behaviors, although diet really does contribute to some biological factors as well, because it manifests in your health. And so there's, again, a bi-directional relationship there. Great. Thank you guys for chiming in with that. One of the things that I wish they would have done in this video is to deep dive into diet a little bit more, and to see how the food choices we make in a day-to-day can also contribute to this construct, this understanding of social determinants of health. Great. The COVID-19 pandemic has contributed, has really changed, has had a staggering effect rather on people's health, on our culture, and on our economy. Food security is a determinant of health. It's usually related to the socioeconomic position, so that box of variables, usually related to income, occupation, other variables such as that. And food insecurity refers to how reliably a person or a family is able to access adequate amounts of nutritious food. And here we can see a recently conducted study and graphic from the Brookings Institute that shows how food insecurity increased dramatically from 2018 to April of 2020, so just earlier this year, especially in households with children. And so what we can see here is that in 2018, the levels of food insecurity were maybe as high as 15%, and again in these different groups, but that as of April 2020, when the survey was conducted again, it could be as high as 40% among mothers with children 12 years and under. And so what we can see here is that social and global and societal conditions such as the COVID-19 pandemic can have dramatic effects as a determinant of health, particularly in this example through food insecurity. And just for reference, households and children are considered food insecure if the respondent indicates the following statements were often or sometimes true. And those statements are that the food we bought just didn't last and we didn't have enough money to get more. And the second statement is that the children in my household were not eating enough because we just couldn't afford enough food. So those are two statements when households are sampled or contacted for this survey. If they answered Often true or sometimes true, it was considered a food insecure household. I really liked Michelle's story. This is one of the assigned videos in the materials to review. And as it says there, Michelle Simmons is a patient, mother, grandmother who understands firsthand the impact of health disparities in her family and in her community. Michelle had family members with diabetes and heart disease, including her mother, who succumbed to heart disease. One of the things I liked was when Michelle was talking about how she enjoys preparing healthy meals with her family, and that really started when her daughter went to college and came back with a different diet. What I really liked is that instead of pushing against change, Michelle was able and willing to try it, and from there build healthier habits that also strengthened her relationships with her family. That is really compelling, to have an open mind to say, all right, let's see, maybe what I'm doing isn't the best for my health, and really to try something else, especially when a family member or someone you trust, someone you love, a close friend is also making those changes. She commented that she had been accustomed to eating fattier foods or different foods in different ways, but that she realized that might not be supporting the best health for her, especially as she saw her elders get sick and die. Her open mind and willingness to build these new habits for her health and the health of her family was really inspiring to me, and it's something that I could identify with. Her story also shows how cultural practices around food can be held up to the light, and individuals can choose for themselves whether what they're accustomed to doing is really in their best interest, or it's really what, they can choose for themselves if they want to keep doing that or if they want to try something else. And I think that that's an important practice as well, is for us to look at our habits and to say, think about it, examine it, hold it to the light and analyze, is this really helping me to live well? Is this helping me to thrive? Is this helping me to connect with my family, my community? These are important questions to ask. So Michelle also joined the Community Advisory Board of the Academic Medical Center in her city, which is a direct way she can contribute her point of view and guide their activities to benefit individuals as well as her community. She's a go-getter, very involved. I liked this video a lot. Another video that spoke to translational science, actually Barbara covered a lot of this, the different phases of study, and this is a really important part of translational research. So this video discussed the different phases of development that it takes to bring drugs, devices, and diagnostics from an experimental idea to a marketable intervention or technique. And each successive phase provides a stronger level of evidence that the new drug or device or diagnostic approach works as intended and is reasonably safe. This from bench to bedside, that has been part of the National Institutes of Health programmatic emphasis on streamlining the translation of discoveries made in labs to effective, innovative therapies for patients and populations. And this adage, or this initiative, this emphasis on translational science from bench to bedside has forged a couple of generations now of scientists and researchers with that aim. From bench to bedside and back again has actually helped to define and expand translational science and also create interdisciplinary research enterprises like the CTSC to identify and support the best, most promising endeavors in science and across health disciplines. Furthermore, to identify and support the best, most promising professionals and across different contexts, across different applications, and even more, and even across the community. So as director of the Nutrition Metabolic Research Corps, our research is usually testing different dietary formulas, nutrients, and interventions on nutrition-related behaviors rather than newly developed drugs. This difference makes our research generally safer than drug trials because we're working with food and diet and more accessible to clinical researchers across different disciplines, which is great. Everybody eats. And so, nutrition and diet is actually an avenue that can be included in research and adjusted in research with really great hypotheses. Before we proceed with studies where we test the effect of like a full-scale experimental diet in patients, the components of the dietary intervention have often first been tested in a bench laboratory in cells or in vitro research, as well as in animal models, and yield favorable results for it to move forward to human research. These initial in vitro and animal models are important steps to demonstrate the proof of concept that the hypothesized effect of the dietary intervention will do so in that system. Also, a benefit of working in nutrition research is that we can often find real-world data on nutrient intakes and eating patterns that are already evident in humans that can support new ideas and innovation in nutrition and how nutrition can be used as an active agent in health or as an active agent in the recovery from an illness for both individuals and populations. So the Clinical and Translational Science Center is committed to advancing medicine and the health of individuals, families, and communities. Each of the gears in this graphic reflect a team dedicated to working collaboratively to create, test, develop, and implement innovations to improve health outcomes. The CTSC seeks and supports creative, promising research across a wide array of disciplines, including cancer and oncology medicine, metabolic diseases such as diabetes and cardiovascular disease, but also innovations in totally different fields than medicine, including engineering, software development, genomic science, infectious disease and vaccine development, which we've touched on a bit, the opioid crisis, and even more. So the Nutrition and Metabolic Research Core is a team and set of resources within the Clinical and Translational Resource Unit. Let's move on to our team and what we do. So as it says here, our team collaborates with physicians and scientists to provide services for research that are related to diet, nutrition, and indicators of metabolism, such as body composition and metabolic rate. Furthermore, we really take pride in our education initiatives here because we also train medical students, fellows, and dietetic interns in the methods and practice of nutrition and metabolic research. So let's talk a bit more about what nutrition research is, because I think sometimes when we can actually put concrete ideas next to these terms, you really get to see how broad this field is and how much potential there is when we're looking at food, nutrition, and diet. So what is research? Let's start with that. And that's really the systematic study to determine new facts and create new knowledge. And when I first heard this definition of research years ago, that research is really to create new knowledge. That's the whole point of research, is to test things that we don't exactly know the answer to. We have a pretty good guess, and that's what founds our hypotheses. But that research and research careers are really, the purpose of them is really to create new knowledge. Now into nutrition. So what is nutrition? What fits under the nutrition umbrella? And that includes, of course, food and diet. This can be research into food composition. So what are the micronutrients that make up a certain whole food, like a potato, for example? What are all the nutrients in potatoes? And if you grow potatoes in all the places potatoes grow, do they have the same micronutrients in all of those potatoes? That's an example of food composition research, is looking at, what is the composition of potatoes, for example. But this can also be patterns of dietary intake. When people eat during the day, people who eat breakfast versus compared to people who don't eat breakfast. That can be a dietary pattern, for example, that you might investigate in research. It can also be the types of food that are consumed that make a dietary pattern. Is it a vegetarian style diet? Or is it an omnivorous diet, which means it has both animal products like meat and dairy in it, as well as plant products in it? Where a vegetarian diet excludes meat. Other things that can count as nutrition research are more specific micronutrient studies, where we're actually looking at specific nutrients. Instead of looking at maybe the composition of a potato, it might be looking at vitamin C specifically, where we're going to study the effect of vitamin C in this specific illness or in this specific age group. And so that would be really micronutrient or nutrient-driven research. And yet another type of research that fits under this umbrella, this topic area, is looking at nutritional status or the level of nourishment of a person. And this really translates as well to health, as well as some effects that can result from advanced disease. So for example, for some people when they develop cancer, their metabolism is so increased because of the cancer that's growing that it actually wastes away some of the lean tissue, so some of the muscle and the fat underneath their skin. And so that would be a level of malnourishment or cachexia or wasting, it's also called, that could be researched. And so also, looking at people's health status and their level of nourishment also counts. Similarly, if we have research where we're looking at a specific nutrient, we might see how that is metabolized and how that contributes to nutritional status within a person. And there's actually a lot more that fits under nutrition, but we'll save that for another day. So a few types of studies, we'll talk about that here, but one of the really important concepts to understand is that every study starts with a compelling unanswered question. This is called the research question. And then the research question is the point of doing the study, and it drives the study design, the data collection, so what variables are we measuring, are we actually imposing a treatment or a change, what data are we collecting, and how are we going to analyze those data and report it out. And so that's something really important to keep in mind when you hear headlines about studies, is that oftentimes the best research is designed and implemented, carried out to answer one very narrow specific question. And so sometimes headlines take, especially nutrition studies, and they'll say, well, the study didn't answer this and didn't answer this. And it turns out it's not significant if it's not significant for weight loss if, you eat this food or that food. But oftentimes the studies necessarily weren't designed to answer the question that headline is talking about. And so that's unfortunate, and it happens in nutrition nutrition media, or when media reports nutrition research, actually a little too often. But the important thing to keep in mind is that the research question is part of the initial stage of all studies. What are we going to answer? Why are we studying this? Why is it important? How are we going to study it? So in terms of types of studies, there are two broad categories. There are observational studies, and these are studies that don't impose any treatment or change. They really just observe people, and they collect data on how they normally live their lives. And so in the context of nutrition research, this would be contacting people and surveying them or asking them about their diet and their usual eating patterns. It also includes lifestyle patterns. So a lot of times observational studies, they're also called cohort studies, where a cohort of people is recruited to participate in a study, and they may be followed for many, many years. And every 2 years, they're sent a packet of surveys in the mail, and that's how we can get data on how people are living their lives. And there are actually quite a few long-running observational studies from which we get really great dietary data on what are people eating, the people who live the longest or are the healthiest, what were they eating all of those years that they were, working up to this greater longevity. Observational studies are usually called hypothesis generating studies, that because since there's no treatment imposed, there's no experiment, it's really observational. It says it's meant to generate hypotheses. It's meant to generate these ideas of what would be a really good research question. Great. That brings me to the next type of study, which is an intervention study. And this is when a treatment or a change or something new is imposed on those participating in this study. And so we really need observational evidence that starts the idea of, okay, this is the relationship between an exposure, such as a diet or say a type of food, something, maybe it could be physical activity, right? In the observational studies, if we see that people who are more physically active tend to live longer or tend to get fewer hip fractures, for example, it might be a very interesting intervention study to randomize people to a physical activity intervention versus their usual life, right? And then to see if the people who had the physical activity intervention, if they really do have fewer fractures or have better health in the long run. And you would compare it to the usual care. And so you want to, in intervention studies, you want to make sure that you're not withholding helpful treatment from anybody. However, to innovate and to see if this new treatment is actually effective, you can compare the intervention, the study experimental intervention, with what would be the participants' usual behavior or their level of usual care. All right. So from there, I'll move on to discuss the Nutrition and Metabolic Research Core, and what our role is to provide services for approved clinical research that engages the Clinical and Translational Science Center at Weill Cornell here. And some of the services we offer are nutrition research design and consultation. And as I mentioned, the research question really drives how the study is designed, what data are collected, and how those data are analyzed to be reported back out to answer the research question. And you really want to make sure that, especially with something like nutrition, which can be hard to measure and even hard to keep track of, that the studies are conducted, or rather designed and then conducted as rigorously as possible. We also do anthropometry and body composition assessment. And so anthropometry is actually just a longer way of saying we measure bodies. So weight, for example, is an anthropometric measure, measuring a body. So weight, waist circumference, also the circumference of the upper arm, those can all be indications of nutritional status. The body composition assessment we do in a couple of different ways, and what body composition assessment is to determine or to assess what the balance of fat mass and fat-free mass is in a body. So fat mass is pretty self-evident. That's the amount of fat tissue in the body, and fat-free mass is actually a couple of different types of tissue. So that could be bone, it could be lean muscle, it could be all of the water that's in our body. It's anything that's not actual lipid or body fat. And we have a couple of devices that do this, which I'll get into in a moment. We also measure resting energy expenditure using indirect calorimetry, and I'll talk about that also in a moment. Another service that we offer is staff training for multi-center trials. And so a really important thing when a study is being planned, as Barbara spoke to earlier, it can take years in multiple stages and phases for studies to, or for research rather, to vet either a drug or a procedure or an intervention, and actually to get that to something that's implemented, or either a marketable drug, or that could be a practice guideline, a clinical medicine practice guideline. And so there's a lot of research that happens in between. And so what we do is we want to make sure that all of the studies are being conducted, especially those that are at multiple sites across the country, that everybody on the research team is on the same page and is working with the same set of information. Some of the available tools that we have in our core are, of course, our expert staff and our anthropometric measurement equipment. So obviously scale, stadiometer, which measures height, circumferences are measured with a tape measure. And you want to make sure that the tape measure isn't something that can expand. So you wouldn't want to use anything that's elastic, obviously, when we're measuring circumferences. And then we have the bod pod, which is actually behind me here. I'll show you some pictures of it in a moment, for assessing fat mass and fat-free mass, the body composition. We also have a bioelectric impedance device for body composition assessment. And that device is actually about the size of a briefcase, so we can take it around to other parts of the medical center where research is being conducted. And that device uses an electrical current that you can't feel, or anything like that. But based on the speed and how that current moves through the body, it can tell us whether or how much of the tissue is bone, skeletal muscle, water, and fat-free mass. Fat or dry fat mass and fat mass. Dry fat-free mass and fat mass. Anyway, it tells us several different types of tissue that are in the body, which is really helpful. Also, we have the metabolic card for indirect calorimetry, as I mentioned. So this is a device I'll show you a picture about. What that tells us is how many calories somebody is burning at rest. And this can be really helpful because normally we use equations to estimate, based on somebody's age, sex, height, and weight, how many calories they're burning at rest. But if you have a patient, or if a study is investigating people who either there's an imbalance, they either weigh more or much less than would be expected based on these equations. For example, like if somebody has advanced cancer and they have that degrading lean tissue that I mentioned a few minutes ago, right? That would be a really good application to find out how many calories is this body burning at rest, and then adjusting their nutrition, the nutrition provided to them accordingly, so that they can stop wasting as much tissue as possible. So we have a few neat tools. Now let's see, what are some of these tools? What do they look like? So the indirect calorimetry that I just mentioned there, to assess energy expenditure, what we do is our patients come in, this is me giving an example, but they'll wear this mask here, which is just a neoprene mask that captures all of the air that's breathed in and out. And in this mask, it connects to this machine, and the machine tells us what actually is the composition of the gases that are exhaled. And based on that composition of the gases, the types of gases that are breathed out, that actually tells us not only how many calories somebody's burning at rest, but also what kind of fuel they're using. Is that person using mostly fat to support that energy level, or are they burning carbohydrate mostly to support that energy level, or a bit of both? And this printout here shows us, is a printout from this machine, where you can see here VO2 and VCO2. Those are the gas exchange that is measured, and then the REE is the resting energy expenditure, and the RQ is the respiratory quotient. And this is that indicator of which fuel is being used to support that energy level. Also, we have body composition assessment using the BOD pod. And here, this pod, which as I mentioned is right behind me, the subject sits inside the pod, and the door is closed for about 50 seconds at a time, and it'll need to be closed at least twice. And the person sits in there, and based on the measurement of air displaced by their body, and coupled with a very accurate scale, the device can estimate how much of their body is fat mass and how much of their body is fat-free mass. As you can see here, our model is holding a tube. This is another test that this piece of equipment can do, which assesses thoracic gas volume, or the volume in the thoracic cavity, which is the cavity that has your lungs in it. And that test would be important if you had a subject in the BOD pod who was very, very tall, much taller than normal, or much shorter than normal, or for some reason had a much larger rib cage than normal. Great. So we actually have even more services and more activities that we do for research. And this includes nutrition assessment, counseling, education, as well as monitoring for both groups and individuals. And so this is really the activities that we would do on a study. This could be in one-time sessions with patients or participants in the study, or this could be repeated engagements, repeated encounters. It all depends on the study and the research question and what the study is designed to do. And again, we have expert staff is our chief tool in this area. And I can't say enough about our team and the Nutrition and Metabolic Research Corps, because amongst us, we have more than 100 years of experience in research nutrition, which is pretty incredible. And here's a picture of our team there. We also have nutrient analysis software, and our staff here, Helena, she's the one that really leads our nutrient analysis software endeavors, which is fantastic. It's really helpful. And what we can do for that is we can actually assess dietary intake and report back to the researchers what participants in the study are consuming, as well as like a nutrition profile of what their diet is like. We also prepare and serve research diets that include weighed diets, macronutrient or micronutrient controlled diets, as well as balanced diets. And we can do that inpatient, so for patients who are hospitalized here. Otherwise, we can also do that in an outpatient context. And really, our gem of a tool for this service is our metabolic research kitchen. And so we have a fully functioning commercial or institutional food service enterprise where we can create full diets or formulas from scratch, and we can prepare and serve those here to our patients. Here we see one of the things that's characteristic of a metabolic kitchen is that everything is precisely weighed and measured. That's a really important part of nutrition research. Not only in research do we need every part of the study to be done rigorously and consistently again and again and again, but for nutrition studies, it's very important that we know exactly what is going in the dietary intervention that we're testing in that study.
Dr. Hootman, you have about 10
yeah.
minutes left.
Okay, wonderful, thank you. And here we have one of our staff, Beverly here. She's been with us for more than 50 years. She has been with this institution, and so I welcome the opportunity. I love to learn from my staff of what they've encountered over the years in nutrition research and really how the institution has changed, but also how it's stayed the same. There has been a metabolic research kitchen here since 1960 in some form or another. And so the CTSC in its most, in its current iteration is only the most modern version of a nutrition research enterprise that has existed long before that. It's really exciting to be involved with it here. So in these last few minutes, I really had a few questions for discussion. I really liked the videos. I thought they were approachable. But as we've gotten to talk more about nutrition research, and hopefully as you all hear this, you're thinking about your experience, right? How does this affect your health, or how does this affect maybe the health of your family or your community? So the first question I really wanted to hear from the group, from each of you, is can you think of a nutrition-related issue that affects your health, or the health of your family, or the health of your community? And if so, and you can just chime in.
Well, if I can chime in, I do think that for me and my family, I'm from a very large family, and no one is overweight in my family, but we all eat everything.
Wow.
People have always asked me, you always hear people saying, if I eat that, it's on my hips the next day, that kind of thing. I realize that there must be some sort of genetic component also. I mean, my family, no one's gorging themselves, but I think it's really interesting when you think about being overweight and food, that people are perceived as gluttonous when they're overweight. And it's something that is interesting to me is the idea of being overweight, because I can't really imagine how a person gets fat, but
Right.
that's just my experience.
That's so interesting. That's
You
so
got
interesting.
those good genes, Miss Jackson.
That's right.
Well, in my case, though, I do have to say that I did have cancer, and I've recovered from it now. But that wasn't true my whole life. That's only been true in the past, year and a half.
Wow. So that's such an interesting point. And I think that's so interesting because from your point of view, it's hard to imagine how obesity would happen. right?
Exactly. Yes.
And from the flip side of it, there are lots of people that are in the other boat where obesity happened and they're not sure how, or it's equally puzzling just on the flip side of that. And genetics are definitely a component. However, there was a great paper that came out in the New England Journal probably about 10 years ago now. The author's name is Christakis, and it was about social networks. And the results of the paper were in the Framingham offspring study, or maybe the first Framingham cohort. Anyway, there's a small town in Framingham, Massachusetts, where the people there have been followed for a long time. There was a cohort study that started there. Anyway, the findings from that paper were that people happened to have a BMI that was similar to the closest members in their social network. The people that they spent the most time with, they were more likely to have a BMI like that, the body mass index, or the weight for height index, right? That your BMI was more likely to be like people in your social network than it was to be like that of your biological family. And so it's interesting to hear Ms. Jackson's comments about that you have a large family, and that that was an element growing up, is that everybody in your family was lean, even though you could eat everything. Although it was really interesting that you pointed out that you weren't gorging yourselves, right? And so we do things a lot like our social networks, and when we're living with our families, obviously, or have large families, someone in your family is probably always in touch with you, and or at least is about to be, and so they actually a lot of times large families become a really important part of the social fabric of our lives. And so it's interesting, there are genetic drivers, certainly. Obesity specifically has come out as being very, very complex, that there isn't just, one or two genes that is responsible for the by and large obesity. In fact, the genetic causes of obesity account for, I think, less than 1% of obesity cases, and that's a couple of rare syndromes that we do know are genetically linked. But for the vast, vast majority of obesity, it's really not driven by genetic factors. And so in familiar or social group circumstances, it's acknowledging the social factors, how much people eat, do people go back for seconds, what kind of foods are people choosing, those are all factors that can hang together with families, but are also these kind of social determinants that we talked about earlier. Great, thank you for that.
Dr. Hootman, Dr. Hootman, to pick up on that point, just as an aside, Framingham, Massachusetts, I knew a family by the name of Smith, S-M-I-T-H, several generations lived in Framingham, and I'm familiar with Framingham, and it's a beautiful place. So I'm so intrigued by that cohort study. If Agnes could get me some information on that, Agnes, I'll email you later. I would love to read it. On the point, however, what topics in health research interest me the most, as a corollary to what you just said, debunking the myth that genetics make us thin, medium, or otherwise, I'd love to learn more about what are successful strategies in behavior modification around food research.
Whew, that is a huge topic. Thank you so much, Ms. Scanlon, for chiming in. Yes. So behavior modification strategies and food research, they're overlapping, but they aren't exactly the same thing. And so it really depends on what your goals are, right? The behavior modification, again, like the research question that would go with what you just said is, what is the behavior that I need to modify to meet this nutrition related goal? And we were coming off an obesity conversation. Maybe the behaviors you want to modify have to do with overeating, or whatever behaviors will get you to a lower body weight, right? That might not be everybody's nutritional application, right? Maybe some people want to change their behaviors to reducing their blood sugar, for example, or to reducing their risk for heart attack. And those might not necessarily be weight loss directly, but yeah, that's a really huge area of research actually, is how do we change our behaviors, and what are the behaviors we need to change to meet this objective, another objective, and even yet another health objective. So yeah, that's a huge topic. Great. One of the last questions that I'm really interested in as well is, for you as participants in this class series, thank you so much for your time today. How do you envision translational research could help you or your family or your community? Like, how do you see yourself benefiting from translational research?
Well, I think, Dr. Hoopman, first of all, thank you. I think it educates, it illuminates, it advises, it takes the screen back, it brings front and center a core information that disturbs and disrupts and displaces a lack of education, a lack of familiarity, a lack of comfort base level with how we talk about food as much as how we ingest, eat, and enjoy food. I think to demystify, to the extent that research and institutes with which you are involved and advancing their core values, to the extent that the public can be informed in a very concrete, specific way, how that information then leads to change perception around food, and translates into active doing pieces around food. That all, to me, are the building blocks that support societal change, and eliminates the likelihood of disease and distress that emanates from a lack of information, a lack of education, a lack of understanding about the per se correlation between behavior around food and public health outcomes. Why diseases grow based on why we lack information about what we're ingesting in our body, and therefore either creating disease or eliminating disease based on what we learn and how our relationship with food is transformed, so that food becomes a resource tool and a research tool to educate the public around better public health outcomes. That genetics is a driver, but what we know and what we do, our action around food, how that transforms societal public health. Thank you.
That's fantastic. Thank you. I mean, it's a bringing together of all the stakeholders. What do we know and what positive change can we make to advance health? Excellent. Thank you so much. And is there one more question I see from Larry? Mr. B.
Hi, thank you. Taking a totally different direction. Right now, one of the major problems we're having socially is a third of the country doesn't believe in science. Oh, doctors don't know anything. My Uncle Albert told me he smoked till he was 97. Smoking doesn't, yeah. The original question about the value of translational is it has an opportunity to bring people closer to the lab bench, to see the process of science, to start to learn to believe in it again. Back after World War II, science saved our ass, pardon the phrase. Came that nuclear mushroom cloud with salvation as the lab bench. Oh, he's at the Institute. He might as well walk on water. These days, oh, he's a scientist. I believe there was a quote, the FDA is unduly influenced by science. I couldn't believe I heard that, but I have heard that. That might be what translational can do. That's spooky.
Yeah, that is
beyond weird and disturbing. That is spooky. unduly influenced by science.
Right, they should be properly influenced by science, you would think.
I want to do a public service thing that's a Republican ad saying, water runs uphill. Our dear leader said so. It runs uphill. And anybody says so, it's false, fake news. Sorry,
Well,
no politics.
Honestly, get involved in your community. Exactly. Like being an activist for ideas, activist can be an ugly word sometimes, but really sometimes it is really correcting misinformation, especially among people that we know and love, and even people that we trust who give backwards ideas about things. I was actually just on a conversation earlier this week about misinformation on the internet, that I think in, years past, there was just much less information that we were bombarded with on a day-to-day basis. And so it was easier to tell the credibility of things, I think, maybe 10 years or 20 years ago, because there was just less nutrition or health, or there was just less controversy, I think. Although nutrition's always been kind of a controversial topic, at least for the last 60 years or so. But now, really with tons of misinformation on the internet, everybody's got an opinion, and everybody can broadcast their opinion loud and proudly for everyone to hear. And that can be kind of misleading, especially if you're trying to find information on a topic that's new to you, that isn't your area of expertise, and you're not really sure what experts to reach out to. And I would also kind of point to that medicine and science are not always joined. They're not always collaborative like they are here at Weill Cornell, where a lot of times physicians, their specialty is medicine and caring for the patient. And many times physicians really aren't on the leading edge of what's working in science. And so I would actually, talk to my family and friends to really not equate the two, that science and medicine are not the same thing. And so our medical experts are not always going to be our experts in science.
Sadly, my experience is that physicians are to engineering what physiologists are to physicists. Most docs are pragmatic engineering types, but they don't always have first-rate current physiology.
Sure. Interesting. Thank you so much.
And we have Niger has his hand up.
Oh, great.
Hi. So I've been reading or responding to the question of like what topics in health research interest me and
Yes.
why. For me, it is more on a personal level with diabetes. Like I come from a big family. The men are all small. The women will vary, but and even nutritional, like the way everybody eats, will vary as well. Like we never had diabetes in the family until my grandmother got it. And then a couple of years ago, she's the first case of diabetes in the family, period. And then right behind her, my uncle, who doesn't live with her, didn't even live in the same state, got diabetes like 2 months after she was diagnosed. With me and my sister, like I've always been smaller, active, good diet and everything. My sister, not active. Her blood type should be sugar, like syrup. And as of right now, I'm pre-diabetic, and she's fine. So
Wow.
For me, it's crazy. Like I know it's not really so much genetics so much, or at least I wouldn't think so, since my grandmother was the first case in the family. But then I also feel like there's something either happening in my body that isn't happening with hers, however it goes. But I'm sure that it just, for me, it is more. It just doesn't make so much sense to me that I would be the one that's pre-diabetic, while, like I said, she's fine.
Right. And I thank you so much for sharing that, because that is really interesting how you can look at your habits and next to especially someone in your family, and
Mm-hmm.
it doesn't make sense right away. Diabetes is interesting in that oftentimes, on average, a person has actually had high blood sugar
Mm-hmm.
for 7 years before they get diagnosed with diabetes. And this isn't high
Right.
blood sugar after just like a meal or here or there. This is having
Mm-hmm.
chronically high blood sugar again and again and again. And so
Right.
a lot can happen in that window, right? And it's 7 years on average. For some people, it might be 5. For other people, it might be 10. And so that can be
Mm-hmm.
something that might be happening with you and your sister, is that if you've shared the same habits and lifestyle, especially, you know, if you're sharing these habits in your family, right, with other people who have
No, but we
gone on
don't.
to
That's
develop.
what makes it interesting. We don't.
Yeah.
Like I said, she's, you know, always eating like the fried, fatty, high preservatives, like all of that kind of stuff. Steady diet since we were kids. Me, the opposite.
So even in the same household?
Yeah.
Wow. I mean, that's really interesting. It's great that, you know, you guys were able to access different foods. And the fact, if you have pre-diabetes, that means that, you know, you can prevent it from becoming diabetes with changes in lifestyle. And and honestly, sometimes, I mean, often comparison is the death of satisfaction, I think, was that the quote by Whitman. But comparing ourselves, and every body is different, comparing ourselves to one another, even to people in our family, can really just be this futile, kind of frustrating exercise. I know I have a sister as well, and we have some really big differences between us, and some of our similarities are puzzling to me as well. And so, yeah, I'm glad that you're looking, you know, at least you're familiar with what your dietary choices have been, and looking back how they've been different from your sisters. And going forward, I would really like focus on your choices and what you can do to optimize your health, just like Michelle in that Michelle story.
I am.
Yeah.
No, I am. Like, I just find it weird.
Yeah.
I just find it weird. Like my mom, like even with my mother's cooking, like she always cooked on the healthy side. So my sister will, you know, like that's, you know, her choices were her own, and it was just different from from the households. So
and she
that's what
rebelled
makes
on
it
the
weird.
other side.
Right. She was just like, you know, I need all this, you know, like she would have ice cream for dinner, like literally eat like a pint of ice cream and grapes for dinner instead of actual food, because she's a sugar addict. And she's always has been. I just always found that very interesting. For me, I could take it or leave it. For her, she got to have it. So, and
another thing I might chime in with,
crazy.
Another thing I might chime in with is age can have a really big effect on this as well. So like while we're young, our metabolism is like really flexible. We can do all kinds of damage to it, and it still seems to work just fine. And it's really as we age and mature that that there isn't that level of plasticity, especially if we're having, you know, a year after year of poor dietary choices or low physical activity, especially if, you know, if weight is changing or not. Sometimes it can be metabolic changes within that take time to add up, but also if they accrue in this more mature period in life, they can have more like deleterious effects. It's more bad things that we can see, rather than when we're young, we can do a lot of abuse to our body and it tends to bounce right back. Yeah, thank you so much for sharing. So I see that we're at about 3:11. Are there any last questions or comments? Otherwise, I'll say thank you so much for your attention and time today. Here's some more pictures of our team. There's Barbara and I with these beautiful flowers, and our staff in the Metabolic Kitchen. And this is actually a shot of the Metabolic Kitchen here at NYP, and you can see everything is in its own like particular morsel and labeled and packaged to make it easy to serve and straightforward for patients. So if there are any other questions, I'd love to take them. Otherwise, thank you so much.
Yep. Thank you. That was really interesting.
I don't see anybody in the chat.
Thank you. Lovely talk.
Thank you. Thank you all for attending. Thank you, Katie. Thank you, Barbara. I thank everyone who was on the call. It was a great, I enjoyed the meeting, but I enjoy always, but I enjoyed the meeting. Thank you for coming. And if you have any additional questions, you can shoot them to us and we will send them out to Katie and Barbara, and I'm sure they'll answer. But looking forward to next week's session. We go back to our old time, and I thank all of you. I will also be sending out information on the project that we want you guys to work on. So start looking in your community, look through the lens of a researcher, look at conditions or ideas that you would like to do research on or you'd like to talk about. For example, if you're looking at the fruits and vegetables, you could take pictures of the fruits and vegetables in your community that are in the bodegas. If you can show people's faces, But if you were interested in, let's say, the opioid epidemic, you could take pictures of the needles, if there are needles lying around in the street or in the gutter. But we will send out more information. So start thinking that you're the researcher and you want to talk to people about what's on your mind. And you want to talk to people who have the possibility of helping you change the situation. Okay?
Is
So
this, is this a project that we're going to write up as if it were a term paper, or are we supposed to actually go to completion? And then there's human subject investigating committee and funding and statistics and all that fun stuff.
All of that's a possibility. I'm working on the little pieces that go with it. So one step at a time. So right now, just come up with an idea and take pictures of it like for a photo novella.
Be careful what you
Okay?
ask for. I would love to talk to you people. I really would. But I won't inflict myself on you. Thank you so much. It was a lovely, lovely talk.
Oh, thank you. I thank everyone for being here today. Thank you so much.
There was a question from Ms. Jackson. She said it was very interesting stuff. Can we research something that is not a problem?
Well,
What
sure.
I mean, what I mean by that is maybe look at something that is successful and research the success of something.
Oh, okay. That's a great. Katie gave it a thumbs up. So that's
Okay.
good.
I'd say that sounds like a great idea. That sounds like, turning a question on its head, and sounds like there's already a good idea behind it.
Well, I like that idea, because I'm in a neighborhood where a lot of people are turning to vegetarianism, and I think that's particularly interesting.
There you go. You might look into best practice research. So the kind of research you're describing on examining really what's working well, you might look into sort of best practices as a format for examining that in a community context. Otherwise, run with your idea.
Okay, thank you.
Okay.
Okay, no more
All
further
right.
questions I see. I will also be sending out a Google form, so if you could just take a couple of minutes to answer those questions at your own time. Also with, maybe if Dr. Hoopman could send me the cohort study for Ms. Scanlon.
Oh, sure. The Framingham stuff. So you can honestly Google Framingham cohort. They have the Framingham and who they recruited in the 1960s, and then they recruited their kids, which is called the Framingham Offspring Study. There are like 1 trillion papers from those studies, but sure, I'll find some links and send them along.
Okay, thank you, and I'll pass it on to everybody.
Would you know if their blood bank is contributing to the All of Us project?
So the All of Us project is so new, right? It's just getting started.
I know.
So the All of Us hasn't really created a blood bank to really merge with any other blood bank. And actually the way that those resources are merged is the data that has been extracted, we'll say from the Framingham blood samples, right? So the blood has been analyzed and we know how much vitamin C is in it and how many red blood cells are in it, right? For everybody in that study, for every time they donated blood. What that is it's sitting in a spreadsheet or a database, really. And so when the All of Us study has their samples, whether they're blood samples or whatever specimens are collected, they too will be analyzed for, a certain set of constituents, right? What's in this blood? And then that too will generate a database, which then can be merged with the data from the Framingham and other cohort studies. So that's often how the data is pooled to get stronger scientific findings.
I was asking a different question. All of Us is doing precision medicine. They want the genetics. So the question is, will there be, does Framingham still have the blood? Do they have a blood bank?
And they run genetic studies. Yep.
That would be really interesting. I don't know where they are yet. Okay.
The genetic studies in the cohort studies is really interesting because you can see how genes actually associate with conditions that people developed later in life, like complex conditions like obesity or cardiovascular disease. You can see if there are any genetic drivers, which they had, before, when the study started, before they got those diseases. You can see whether there are any genetic predictors of whether they'll go get those diseases later.
My hunch is that obesity, much like dyslexia, there's no such thing called dyslexia. I think of it as the dyslexias. We have a problem with reading, but there are many different ways that happens. And my hunch is physiologically, there's more than one way to express obesity. So you won't find one gene that causes obesity because there are multiple types of obesity.
Right, and yeah, exactly. So for like 98% of cases of obesity, it's not driven by, it's not largely driven by genetic factors.
As you said.
Yeah. Okay, great. Thanks everyone for your feedback and have a great day.
A pleasure.
Thank you. You too.
Bye.